Here we go. We're going to start with the respiratory system. The respiratory system is important for that gas exchange, the oxygen for carbon dioxide exchange. That is vital. You know, we need the oxygen. Our cells need the oxygen in order to make energy, ATP. Remember, the three main ingredients are going to be glucose, oxygen, and water. So we need those things in our cells in order to make energy. Every cell has to make its own energy. So we have to have a lot of this oxygen constantly coming in. And of course, then it has to get delivered. We talked about that. That's what the red blood cells are for. They are the buses that deliver oxygen around. And oxygen will move into, let me put it a different way. Oxygen will move across membranes following simple diffusion. Remember, we talked about diffusion weeks ago. We said diffusion is when there's a whole bunch of particles on one side of a membrane and fewer of them on the other. And if they're small enough, they're going to move right across. They're going to follow their concentration gradient. So that's how oxygen is going to get into the cells, for instance, whether it's the red blood cells or other tissues in our body. But that's what we're going to get into. So let's switch over to that. When we breathe, breathing in what we call room air. Room air, of course, is the same as atmospheric air. We're looking at just under 21% oxygen. The air that you breathe, next time you take a breath, next time you're thinking about it, take a breath. And the air that's moving into your lungs, that air is actually not 100% oxygen. If it was, the earth would have blown up a long time ago. That air is just under 21% oxygen and just under 79% nitrogen. So most of what you're breathing in is nitrogen, but we only want the oxygen part of it. Then when we breathe out, that air has about just under 17% oxygen. So we only keep a small amount of it. But of course, we're also going to breathe out waste products that we've created. That stuff called carbon dioxide. Carbon dioxide is important actually in our bodies. We do use carbon dioxide in a couple of different areas. One of the most is the production of bicarbonate. So let's talk about the respiratory system. As we breathe air in, a lot of that air is coming in through our nose, and we have these bony projections in the nasal cavity called the turbinates, or sometimes called the nasal conchae. And they have a membrane over them, a mucous membrane, because remember, everywhere we have an opening on our body, we have mucus that's going to trap things. And that is no different here. But it's also going to do other things. It's also going to help to moisten the air, because our lungs are a very warm and moist environment. So the air going in, we want to also be warm and moist. So if it's a bit dry, it can pick up some moisture from those mucous membranes. As it travels around the turbinates down into the pharynx, throat, it's also going to pick up some heat because the lungs are a warm and moist environment. So we want air going into the lungs to also be warm and moist, so we can pick up some of the heat if the air is a bit cold. We talked about oxygen already. It's an important role in making energy. That's the metabolism part. Electrolyte balance, yeah. We will see that carbon dioxide, that waste product that we create, is actually something that we do breathe out, but we also utilize in our blood. We convert it to bicarbonate. and that becomes the most potent buffer that we have in our blood to help maintain that pH. We do breathe out some water. That's why when it's really, really cold outside, you can see your breath. Okay. Yeah, oh, I thought they had the turbinates in there. They do not. All right, so starting with the respiratory system, the upper respiratory system, the nose, the pharynx, and the larynx. Notice the pharynx is divided into 3 sections: nasopharynx, oropharynx, and laryngopharynx. So pharynx is your throat. This is a common pathway, not just for air, but also for liquids when you're drinking or food when you're eating. And it's actually much higher than most people think it to be. In fact, let's go back to this first page right here for just a moment. The larynx actually extends down to, most people, if I say point to your throat, they point to this area right here. But your throat, your pharynx, actually ends right about here, just below, if you draw a line horizontal to the chin. It actually ends right about there. And that attaches to the pharynx, where we find the true, or the larynx, where we find the true vocal cords. If you open up your mouth, stay out your tongue, say ah while you're looking in a mirror, looking straight back, the area that you see is the oropharynx. And then if you had like a dental mirror and you flipped it upwards, you'd be able to look up into the nasopharynx. And if you twisted it, you'd be able to see down into the laryngopharynx. The lower respiratory system contains the trachea, which is the main air tube, what people would call the windpipe. The bronchi, which are the 2 branches of the trachea, which then branch off into smaller branches, which then branch off into smaller branches called bronchioles, and then into the smallest branches, ending in terminal bronchioles, and the alveoli, these little air sacs at the end. And of course, the lungs house all of those small air tubes and alveoli. The lungs are made up mostly of those alveoli. Accessory structures include the diaphragm. That's kind of a big deal. That dome-shaped structure that separates the thoracic cavity from the abdominal cavity. That's kind of an important structure when it comes to breathing, because when that diaphragm contracts, as it flattens out a bit, it is going to change the air pressure in the lungs. It's going to cause the air pressure in the lungs to be lower than the outside air pressure. In other words, air is going to come rushing in. Kind of the opposite of thing that happens to a balloon. When you blow up a balloon, the balloon has greater air pressure on the inside as compared to outside, so air wants to come rushing out. When the diaphragm contracts, that causes the air pressure inside of the lungs to actually be lower than the outside air, so air goes rushing in. That's how we breathe in. And then when it relaxes, air just passively moves back out again. The intercostal muscles help with changing the shape of the thoracic cavity, which is going to change the way that air moves in or even out of the lungs. If we want to squeeze extra air out of the lungs, some of those intercostal muscles are going to contract, and they're going to make the thoracic cavity smaller, squeezing the lungs, forcing air out. Protected by the bones of the sternum and the ribs laterally, the vertebrae in the back. We saw that the nose is pretty straightforward. There's a couple of nasal bones, then there's some cartilage. On the inside part There is the conchi, the nasal turbinates. You may have heard of cleft lips, which is where that child is born with a space where part of their lip should be. But this is going to continue into the palatine bones. So that sort of the roof of the mouth also has an area that's hasn't grown together. It's not complete. That's a little more complicated fix. A cleft lip is really simple surgical fix. Cleft palate is a little more complicated. I think we saw the cribriform plate a little bit when we talked about the skull and the sphenoid bone as it extends out from the ethmoid. And you can see something here. It's kind of difficult to pick out, but here's the nasal bone that we saw a little bit ago. The frontal sinus. There's another sinus over here, the sphenoid sinus. The sinus is an empty space. Now, there is a thin layer of mucus in there. And the reason we have these empty spaces in our bone, in our skull, is to actually lighten it so it is not as heavy. There's no reason to have additional thick bone there. So we have these empty spaces, and that allows it to be lighter. Now, people will say it also changes tone, like when you speak, you sound different. That's true, but that's not really their purpose. Their purpose is pretty simple, just to lighten things up. Ah, there we are. I knew there was a picture in here. So let's look at, first of all, the throat. I want to take you back to that, because the throat starts with the nasopharynx. You can see here, the nasopharynx. So look where the throat starts. Way up here. You can see the nose here, so you can get your orientation. So the throat starts up here. The oropharynx is right here. This is the part right in the back. If you open your mouth, stick out your tongue, say, ah, looking in a mirror, this is the area that you see straight in the back. That's the oropharynx. That's the middle of the throat. And down to here is the laryngopharynx. And this is where it ends, right at this level here. So you can see how that lines up with the chin. So again, if I said to somebody, point to your throat, most people would point to this area way down here. The throat's actually up here more. You can see the nose here, the nares, the entrance to the nose. And these three conchi, they are the concha, the singular, superior, middle, and inferior. These are the bony projections that are covered with the mucous membrane. Again, you'll hear me refer to it as the turbinates, simply because that's how I've always known them. This is the tongue. How big and ugly the tongue is. It's a lot bigger than most people realize. And you can see its connection right to here on the hyoid bone. Remember, the hyoid bone is the only bone in the body that doesn't articulate with another bone. It's an attachment site for the tongue. So as we come down here, coming down the throat from the naso, oro, and laryngopharynx, here it splits. One tube, the one that is anterior towards the front, that is going to be the larynx, and then the trachea, that's where the air goes. And that thin one in the back is the esophagus. That's the food tube. You can see here, esophagus. That's the food tube in the back. So the throat comes down, splits off into these two tubes, one for air, one for food. And we'll zoom in a bit here. The laryngeal cartilage is sometimes referred to as the thyroid cartilage, as it surrounds the larynx, but it is above the thyroid. And it has that laryngeal prominence, which is referred to as the Adam's apple. It protrudes outwards. Everyone has that. The only difference is that on men, it just protrudes much more obviously. But there is this flap that you're going to hear me talk about a few times, the epiglottis. The epiglottis is this lid-like structure right here. That is what flips over, it flips over the larynx so that when you drink liquid or you eat food and you swallow it, we want it to go down the correct tube. We want it to go down the esophagus. So the epiglottis flips over to block the top part of that larynx and of course then the trachea, because we don't want things going down in there. Kind of an important job that it has. The larynx is where we find the true vocal cords. There's a little V-shaped structure that can change shape as air passes across it, which changes the sounds that then you hear coming from me now as I'm speaking to you. So, a lot of pretty simple structures there. Okay. Then, as we move down into, well, you know what, maybe I'll wait just a little bit. I talked about that. Okay. Talked about the pharynx, the throat. Good. The tonsils, you may have heard of these. There are different tonsils, different locations. And if you are looking in a mirror and you open your mouth and stick out your tongue and say, ah, looking straight back, what you'll see if you haven't had them removed are the Palatine Tonsils that are on either side, near the back of near the pharynx. You'll see the little punching bag hanging down. That's the uvula right in the center. And then on either side of that, you'll see these sort of oblong projections, and those are the Palatine Tonsils. Those are the ones that people usually have removed if they have their tonsils taken out. And then just above and behind them a little bit, just out of view, are what are called the adenoids. Well, they're commonly called the adenoids, but they are really another set of tonsils. Those are pharyngeal tonsils. So those are usually removed as well if the Palatine tonsils are removed. The lingual ones, the lingual tonsils are usually not the problem when people have tonsils taken out. So are these things important? And if they are, why do we take them out? Well, they are part of the lymphatic system. So they help in the removal and destruction of particles that don't belong. The problem is that they can get overrun, and the bacteria, for instance, can create infections in these areas. And if this continues over and over and over again, they become more of a problem than they're worth. So then they're taken out. Back when I was growing up, back in the 1930s, everyone, by the time they're about 5 years old, just routinely had their tonsils taken out. It was something that was just done, and nobody really questioned it. And the kids didn't really mind too much because they knew they were getting a bunch of ice cream afterwards. So it was a common practice. However, we know that it's better to keep all of your original parts if you can. Better not to cut things out if you don't need to. So of course now it's not something that's routinely done. It's still done. It's usually done later as the patients get closer to their teen years if they're still causing problems. But again, this is something that we've learned. We don't just take out parts of the body just for fun. I talked about the larynx. Of course, there's going to be mucus all the way down through here because, well, it's an opening into the body. And anywhere there's an opening into the body, we're going to find mucus. Remember, mucus, M-U-C-O-U-S, refers to the tissue type and the cell type that creates the sticky substance. The sticky substance itself is spelled M-U-C-U-S. So if you ever wonder why there are two spellings for mucus, M-U-C-U-S is the actual sticky stuff. M-U-C-O-U-S is the cell and tissue type that creates the mucus. And you'll notice here it says they are ciliated, that they have cilia. And we'll talk about that in just a moment. Let's see. Oh, that's a good picture too. Okay. So, good typical overall view of the respiratory system. Notice we have air coming in through the nose, but we can also have air coming in through the mouth if we wanted to. That connects to a common pathway called the pharynx, or what people would call the throat, which then branches off into two tubes. One's an air tube, one's a food tube. The first part of the air tube is the larynx. This is where we find the true vocal cords, that is surrounded by the laryngeal cartilage. Then the trachea. You can see the trachea is this well-supported tube that brings the air down, and then it branches off into a right and left bronchi. A bronchus is is a tube that is going into the right lung, and another bronchus is the tube going into the left lung. And then you can see them branching off into smaller and smaller tubes, eventually into the bronchioles. And then, of course, beneath that, you can see the dome-shaped muscular diaphragm. So nice overall image. Here, we see the hyoid bone. Remember, the only bone in the body that doesn't articulate with another bone. You can see part of the epiglottis from an anterior view. In fact, let's start with just the anterior view. The thyrohyoid ligament connecting down to the thyroid cartilage, which you'll hear me still refer to as the laryngeal cartilage. The area right in front that protrudes outward, that is the laryngeal prominence. That's what people would call the Adam's apple. Right below that is the cricothyroid ligament. Now, why do you even care about a cricothyroid ligament? This area is the place that gets cut when you see on some television show or some movie where a person needs an emergency airway and they get a knife out and they cut into the area, and then they use like a straw or a pen or something that is hollow to create an airway for the person in an emergency situation. That's not a tracheotomy. Tracheotomy would have to be further down here, and tracheotomy would be more permanent. Cricothyroidectomy is the term for this, and this is more of an emergency situation. It's really simple to do. I'm just cutting through that little bit of ligament. You're seeing the shadow of the thyroid as well as it surrounds the trachea here. There's something they have to notice with the trachea. There are rings of cartilage that go around and support the trachea. However, if you look at the posterior side, notice those rings of cartilage do not go all the way around. They are C-shaped rings of cartilage that are found just on the anterior of, well, anterior and lateral of the trachea. And this is an important thing to understand, because as we breathe air in and out, there is a change in air pressure going in and out of these areas. Now, I know you might be thinking, well, I don't really know a lot about air pressure, but you do. If you've ever tried to drink a really thick milkshake through a straw, or like a Frosty from Wendy's or something, and you try and drink it through a straw, you notice that it gets maybe halfway up the straw and then stops. No matter how much you want it to continue, it's just not coming through. It is too thick. But you really try. So what ends up happening is you end up sucking all the air out of that straw, and then the straw collapses. It sucks in. So with these changes in air pressure that are going in and out of our lungs, passing through this tube, the trachea, there's a change in air pressure that could cause it to collapse. So we want to strengthen that. And the way that we reinforce it is with these rings of cartilage. But there's a reason why the rings do not go all the way around. There's a reason why they are C-shaped. Remember, I said earlier that the throat, the pharynx, is a common passageway for liquids and foods and things. As you drink and eat stuff, you swallow it, and then it goes down the food tube, the esophagus. The esophagus is right behind the trachea, it's just posterior to the trachea. So as you swallow something, that esophagus is going to expand, and it's going to expand into the trachea. Let me show you what that means. I'll show you a couple of things actually, but let me show you what that means. Okay, so let's do maybe a blue for trachea. So here is our trachea, and just posterior to it, right behind it, is the food tube, the esophagus. The trachea has rings of cartilage around this way. So when you swallow something, it's going to go down this way. The esophagus is this muscular tube that has to expand to push down this bolus of food that you just swallowed. So the trachea will allow for that in the posterior aspect of it. This is why the cartilage is only found on the anterior portion of the trachea, on the front of the trachea. Nope, that's not where I was, sorry. Really important thing to remember, the trachea has these supporting cartilage, but it's only on the anterior portion, or mainly on the anterior portion of it. They are C-shaped. C-shaped cartilage just on the anterior portion. And that changes as the trachea descends and it splits off. I'm going to exaggerate a little bit here. Going into the right and left lung, the rings of cartilage are still going to be on these bronchi, but they're going to go all the way around because we don't have to worry about anything behind it. So they can have that full support. Now, one thing I'll point out here is that as I drew the trachea coming down and branching off into a right and a left bronchi, you'll notice I made the right one a little more straight, almost like a straight up and down. It just sort of goes like this and off to the side a little bit, whereas the left is at a much greater angle. It's actually longer. And why is that? You know, you have to remember the heart is going to take up some space in this thoracic cavity. And so it's going to take up enough space where it actually causes the left lung to be smaller than the right lung. But that's why that left bronchus is kicked over at a greater angle. What this means is that if a child is playing with a small toy and aspirates it, they put it in their mouth and then inhale, it's more likely to go down the straight route. So that's usually found somewhere on this side rather than the other side. FYI. Please make sure you check your microphones. Make sure your microphones are turned off. All right. Something else you heard me say. These cells that are in the larynx and the trachea are ciliated. Cilia are extensions of cell membrane. They are what people often refer to as hair-like extensions or finger-like.
Slide over. Slide over, Morgan.
Okay, you might want to turn your microphone off. And Morgan will want to slide over.
She get on my nerves, hold on.
Sorry. So these finger-like or hair-like projections of cell membrane, these aren't things sticking out of the cell. This is cell membrane. And there is machinery that are found inside of these little projections. We'll put the machinery in blue, I suppose. So there's machinery that runs the length of these little projections. And what that does is it causes them to sweep. Cilia sweep. In this case, where we find them in the larynx and the trachea, they're going to sweep in an upward direction. Well, why is that? Well, because remember, there's mucus here. And the mucus is going to trap things. Maybe bacteria or fungal spores or stuff we don't want. So the mucus traps these things, which is great. However, we want to get them out. We don't want them to stay there. So we want to move that mucus to a place where we can get rid of it. So this mucus with these trap particles is being swept upward until it gets to the point to where you can either cough it out or swallow it. So all day long, you are taking this mucus and it's going down the food tube. You're swallowing this all day long. All these trap things in it. Why do you want to swallow mucus like this with all these trapped particles? Well, if you swallow it, it's going to go into the stomach. And if it goes into the stomach, we have something in there called acid, which is going to destroy a lot of things. So we have mucus to trap things. Remember, anywhere we have an opening in our body, we have some kind of mucus that is going to be sticky to trap stuff. But then we want to get rid of the trapped stuff in the mucus. So we have these specialized cells that have cilia, these projections of cell membrane that sweep. And they're going to sweep this stuff in an upward direction until it gets to the point where we could cough it out or swallow it. Another place, by the way, where we'd find ciliated cells would be, as a for instance, in the female reproductive system. You know, that egg that comes from that ovary, that egg has to make its way down to the uterus. And the way that it gets down to the uterus is by two mechanisms. One is it traveling down these tubes. The tubes have muscle in their walls, which is going to cause them to propel, to move that egg. And the other thing are the cilia that are going to help sweep that egg down towards the uterus, which means those are two forces that sperm are swimming up against. They're swimming up against the propulsion of the muscle, and they're swimming up against the movement of the cilia. But that's another way that we're going to get those down. So cilia, I'm not going to do it. Cilia are going to sweep. And in this case, in the airway, they're going to sweep upward. Important thing to kind of get. Okay, so let's see. I talked about the C-shaped rings of cartilage that you definitely want to know about. I talked about the cilia. Okay, good. Notice here they show the thyroid as well as those 4 dots of tissues on the posterior aspect called the parathyroid glands. Okay. I think we talked enough about that. The trachea, we talked about that. Notice again, C-shaped cartilaginous rings. Nice cross section of it here. Notice those little fine looking projections off of the cell. It'll kind of look like hairs almost. But remember, those aren't things sticking out of the cells. Those are part of the cell membrane. And so there's machinery that goes up into those that causes them to sweep. You can see that nice little sweepiness that they could do. So it's a word, sweepiness, pretty sure. You're familiar with this already. You can see now how the laryngeal cartilage at the very top surrounding the larynx, the trachea as it descends. And of course, we've discussed all of these bones, so you're familiar with that. And you can see how the lungs take up most of the space in the thoracic cavity. Not quite as clear here, but the right lung is actually larger than the left lung. The right lung has 3 lobes to it, and you can kind of see a separation of the one lobe there and then another separation there. The left lung only has 2 lobes to it. And again, that's because the heart is going to take up some space where left lung could be. I think you got a picture of that coming up as well, though. Okay, where are we? 54. All right. As air comes down that trachea and it branches off into a right bronchus and a left bronchus, which then branches off into smaller bronchi, which then branches off into the smallest of the tubes, the bronchioles, ending in these little terminal bronchioles. We end up having these clusters of air sacs called alveoli. So let me show you. Yeah. Yeah. Okay. We will see later on that these terminal bronchioles, these little air tubes, end in what almost looks like clusters of grapes, but they're not grapes, of course. They are little air sacs. You can kind of think of them as being like clusters of balloons almost. So if we have this terminal bronchiole and then it ends in this balloon, this alveolus, air, remember that's going to include just under 21% oxygen and just under 79% nitrogen. As we breathe in, it's going to travel down and it's going to cause these little air sacs. You can kind of think of them as like little balloons that are going to inflate a little bit and then deflate as we breathe out and inflate as we breathe in and deflate. It's kind of easy to think of them that way. But we have we have to get oxygen. So I'm going to draw this really close because there's a thin membrane between the blood vessel, this capillary, and the alveolus. I'll just go straight to red. So we know that the purpose of blood is to transport things. And we know that blood is red because it is full of red blood cells. And we know that capillaries are the smallest of the blood vessels. And red blood cells have to go through capillaries single file. And even then they have to be flexible to move through. We also know that red blood cells carry oxygen. And so in this case, I'll use a light blue for oxygen. So as red blood cells go through the body and they drop off oxygen, they're going to return to the right side of the heart, which is then going to pump the blood and those blood cells over to and through the lungs to pick up oxygen. So when we breathe in, of course, we are going to have that oxygen coming in. And that oxygen is going to be in higher concentrations here in the alveolus than in the red blood cells. So by diffusion, oxygen is going to move across all of these membranes, across the alveolus, across the connecting membrane, the basement membrane that's there, across the capillary membrane, and even across the red blood cell membrane. And it's going to do that just following simple diffusion, just because there's more of it here. Now there is a change in the shape of the hemoglobin molecule that also accommodates for picking up oxygen versus dropping off oxygen. But what ends up happening is as these red blood cells come through, they are going to completely fill up all their seats with the oxygen. And it's simply following a concentration gradient. At the same time, the blood that's coming through from the heart, from the right side of the heart, is going to have extra carbon dioxide in the blood. So what's going to happen at this level is carbon dioxide is going to move with its concentration gradient out of the blood carbon dioxide, CO2, so that we can then breathe it out. So there's an exchange of oxygen and carbon dioxide. We breathe in, the air we breathe in contains just under 21% oxygen. And that oxygen is going to be in a higher concentration now as it goes into these little balloon-like sacs called alveoli. The higher concentration of oxygen is going to create a concentration gradient, which is going to cause oxygen to move out of the alveoli, across all of these membranes, and move to where they are fewer, which is in the red blood cells. So that's the driving force here, the oxygen moving across these membranes and getting in their seats and filling up those buses, those red blood cell buses. Then that blood is going to continue to move back to the left side of the heart, where it's going to go to the left atrium, then through the bicuspid or mitral valve, then into the left ventricle, then get pumped out of the left ventricle at just under 200 miles per hour through that aortic semilunar valve and into the largest artery in the body, the aorta. And the cycle continues. So it is at this level, oxygen carbon dioxide exchange takes place. Now, here's something interesting to consider. Where are we? Okay, where are you? Let's go and look at this for just a moment. So if I have my red pen, I have my left hand like this, and I put my red pen right up next to or right really close to my left hand, and I said to you, is my pen in my hand? You would probably say, no, it's not in your hand. I said, well, what about now? Is my red pen in my hand? And you'd say, no, it's not in your hand. And I thought if I said, is the red pen now in my hand? You would say, no, it's not in your hand. If I said, what about now? Is the red pen in my hand? And you say, well, it kind of is. I mean, the hand's sort of surrounding it, but it's not really in your hand. And if I said, what about now? Is the red pen in my hand? You would say, yes, definitely the red pen is in your left hand. The problem with that, it's not really in my hand. I know you're thinking, I'm looking right at it. What is this, a magic trick? No, it's not a magic trick. The red pen isn't really in my left hand. Imagine if your significant other was outside building the deck on the house and started screaming, and you said, what happened? And they said, there's a nail through my hand, or there's a nail in my hand. They said, there's a nail in my hand. You wouldn't expect them to come out and just be holding a nail like this. You'd expect that a nail had punctured through their hand like this. So when I say, is the red pen in my hand, it's not really in my hand. More accurately, it's in my grip. And remember, this is where words matter. The things that the terminology that we use in medicine is really important. So the pen isn't really in my hand, it's in my grip. In order for it to be in my hand, I would have to get a hammer and pound it through this way. Now, why am I telling you this? Why do you care? Because If you think of some place just outside of the nose, just right in front of the nostril, is that inside of your body or is it outside of your body? Well, you'd say, oh, it's definitely outside of my body. Well, what if I got a little wire and I just stuck it just barely inside of your nostril? Would you say it's inside of your body or outside of your body? You might think, well, now it's inside of my body, but it really isn't, because it hasn't crossed a doorway, it hasn't crossed a membrane. So it's not really in your body, it's just in that space. So as I keep pushing that wire back, and it goes all the way back into that area where the conchi are, the nasal turbinates, you would say, okay, now that's definitely inside of the body. Well, technically, no, it's not really inside the body, it's just inside that space. And if I kept pushing that wire back into the nasopharynx, down into the oropharynx, you'd say, okay, now it's definitely inside. No, not really. It's not really in your body. It's just inside of that space. Because remember, that space is continuous with the outside world. Just like this right here. This space right here is continuous with the outside world. So that tube continues down past those vocal folds, and as long as the vocal folds are open, then that wire hasn't really passed through a doorway or a membrane. So technically, a person could get a small wire, go up their nose, into the nasal cavity, into the nasopharynx, into the oropharynx, laryngopharynx, down into the larynx, down into the trachea, down into the bronchi, down to the bronchioles, all the way down into those individual air sacs without going through a single membrane or a single doorway, which means all of that is open to the outside world. So it's technically not in your body. It wouldn't be until it crosses that membrane. And I know that's a kind of a weird discussion to get off on right now, but I want you to hear it, because in a little bit, we're going to talk about how that oxygen moves across these membranes and the carbon dioxide moves across the membranes. And that makes a difference. That oxygen going from one side of a membrane to the other makes a huge difference. So the terminology changes a little bit. So that's why I go through this whole spiel of, is there a pen in my hand? It's in my grip. Questions about that? No questions about that. Okay. Well, just a moment. Oh, that's not what I wanted. Back to the slides. Okay. So you should be able to see my screen here in just a moment. 5, 4, 3, 2, 1. Right about now. Oh, no, that's not what I wanted. Where was the one? Oh, that's right. Almost here. Okay. All right. There's something here in the slide that is really, really, really important. Well, there's several things. The alveoli, those are the little balloon-like sacs, and you can kind of imagine them clustered together. As air comes in, those little balloon-like sacs kind of inflate. As air goes out, they kind of deflate. And again, you can sort of imagine this happening. Now, the problem is, with all these sticky fluids that are found in these areas, and these balloon-like sacs are clustered together, why aren't they sticking together? Why don't they stick together if there's a bunch of sticky substances found around this area? There is something called surfactant. Surfactant is going to keep these things, these little air sacs, from collapsing, keeping them from sticking together. And that's important because it is not made in that baby's lungs until they're into their going into the third trimester, second trimester, going into third, about week 24-ish. This is why the doctors will say that a baby is too young to be born. They will say the lungs haven't developed yet. That doesn't mean that the lungs haven't grown, because they have. They're growing into their places. But what it means is they haven't created enough surfactant yet. Because if you tried to deliver a baby that young and they didn't have surfactant created, as soon as you cut that cord and they breathe in and breathe out, everything would collapse and you wouldn't be able to fill it back up again. You couldn't like force air in, things would just tear apart. So they'll often say that's the last thing that's required for a baby to survive in this world, is for that surfactant to be produced. And notice I say survive, because we know the brain is still developing well after the child is born. We know that even though the eyes have started to develop way back in the first trimester, as everything does, they're not finished really until into the third trimester. So there's a possibility that the baby might be blind or have some visual deficits, but that doesn't mean it can't survive. So when we say this is the last thing that has to be done in order for a baby to be able to survive in this world, it doesn't necessarily mean the baby will be perfect, but will have that ability. So that's an important thing to understand, that surfactant. It's a protein and fat combination that allows those alveoli to be able to maintain their shape and therefore maintain their function. So surfactant is an important thing that you'll hear me discuss a couple of times. So FYI, surfactant. As I said before, the lungs take up most of the space in the thoracic cavity. We'll look at the drawing first. The right lung is larger than the left lung. The right lung has 3 lobes. Notice superior, middle, and inferior. The left has just 2, superior and inferior lobes. The base of the lung is at the bottom where it's more flat, and then the apex of the lung is at the top, although it's not listed here. And that's a little different than the heart. You'll remember the apex of the heart was sort of at the tip of the bottom of the heart. Here, the apex of the lungs is at the top. Oh, it's labeled in this one. Okay. And you can see how the trachea comes down and then bifurcates, splits off into you can see the left primary bronchus is labeled here. What else? That's it. You can see the right pulmonary artery. Remember, all arteries carry blood away from the heart. So if they're going away from the heart, that means they are carrying blood. Typically, an artery is carrying blood that's full of oxygen. However, since these are going to the lungs, they're going to the lungs for a reason, to pick up oxygen. So the pulmonary arteries are the only arteries that carry deoxygenated blood, blood that is low in oxygen. And you can see the two right pulmonary veins coming out. Remember, all veins carry blood to the heart. That's the rule. And they're going to be carrying oxygenated blood in this case. Most veins carry deoxygenated blood. These are the exceptions. They carry blood that is full of oxygen because they are coming from the lungs, picked up oxygen, and they're going to the heart. Then there is something that we discussed before. There is a double layer membrane, a lining around the lungs. We discussed this with the heart. We said there is a pericardium that surrounds the heart. There is a visceral pericardium that's in contact with the heart, and then a parietal pericardium that is the outer layer, and then pericardial fluid in between. Because the lungs also have to expand and then collapse, and expand and then collapse, we are going to have a double layer membrane around them called the pleura. And there is going to be a visceral pleura, that is the lining that's in contact with the lungs. And there is a parietal pleura, that's the outer lining. And then there's going to be a small amount of fluid in between, not surprisingly called pleural fluid, that is going to decrease friction, because one thing the body does not like is friction. So I'm not going to worry about the three divisions, just so you know that there is a layer that is in contact with the lungs and then an outer layer. Oh, wait. Inspiration and expiration. Okay. Respiration. Respiration is one inhalation and one exhalation. You breathe in, you breathe out. That's one respiration. But you'll notice here they have something called external and internal respiration. What does that mean? Well, it's not clear here, so I'll make it a little clearer and a little easier. Internal respiration is when those oxygen molecules, for instance, move across a membrane. It's internal. External respiration is everything else. So air with oxygen moving into your lungs is still external. Air moving into your nose is still external. Air moving into your throat, your pharynx, is still external. Air moving into the bronchi, it's still external. Remember I said it's continuous with the outside world. The only time we really describe it as being internal respiration is when the molecules move across membranes. That's the easiest way to differentiate between these two, the internal and the external. So here is a nice image of how the terminal bronchioles end in these clusters of air sacs called alveoli. And what you can't see, but sort of demonstrated here, is that the capillaries are going to be right in contact. They're going to be sitting right on top of those air sacs, those alveoli. So as blood moves past and we breathe in, oxygen is going to move from the air sacs, the alveoli, into the blood. Carbon dioxide is going to move out of the blood and into the air sacs, and we're going to breathe that out. And you can see here how it's now going to make its journey back to the left side of the heart, into the left atrium, from the left atrium down to the left ventricle, going through the bicuspid or mitral valve. From that left ventricle, blood's going to get pumped out at just under 200 miles per hour through the aortic valve into the aorta, the largest artery in the body, which is then going to pump it around everywhere else, distributing that oxygen, picking up carbon dioxide, and then that blood is going to return to the right side of the heart. It is now deoxygenated. Don't misunderstand deoxygenated does not mean zero oxygen. It means less oxygen. Oxygen has been taken out of it, but it does not mean zero oxygen. In fact, there's a lot of oxygen still in that blood that is coming back to the right side of the heart. It just isn't full. So we use the term deoxygenated, but there really should be a better term like less oxygenated. Not nearly as oxygenated, because I want people to realize that there's still oxygen in those red blood cells in that blood. Then it returns to the right side of the heart and the right ventricle. I'm sorry, the right atrium. Then from the right atrium, it gets pushed down into that right ventricle, goes through the tricuspid valve. Remember, the tricuspid is on the right side, the bicuspid is on the left. So going from left to right, you try before you bi. Tricuspid on the right side, bicuspid on the left. Bicuspid, also known as the mitral valve. That right ventricle then pumps that blood up and out into the pulmonary trunk, going through the pulmonary valve. And then that, of course, is going to go over to the lungs. And this whole cycle is going to continue. So the whole right side of the heart is responsible for blood that is deoxygenated or low in oxygen. The whole left side of the heart is responsible for blood that has been oxygenated. It is full of oxygen. Chock full of oxygen blood is what they should call it. Maybe not. Maybe that's not the right term. Super duper full of blood is what they should call it on the left side of the heart. Super duper full of blood on the left side of the heart. Not as much oxygen on the right side of the heart. Yeah, something like that. What this is also demonstrating here is the feedback. Because of course, if we need more oxygen getting pumped around, there's going to be some way to make sure the body knows this. So there are going to be sensor cells that are going to determine how much oxygen, how much carbon dioxide. Do we need more? Do we need less? Is the pH of the blood the way it's supposed to be? And that, of course, is going to be sent as quickly as possible to areas of the brain. And the brain's going to determine, do we need to breathe more or less? Do we need to take deep breaths or not as deep breaths? I told you before, in order for air to move, in order for air to move into the lungs, we have to change the pressure. We have to lower the pressure in the lungs. And the way to lower the pressure in the lungs is for that diaphragm to contract, that dome-shaped muscular structure. And because it is a muscle, it's going to get shorter. So that dome shape is going to become less dome shape. Some people say it flattens out. It doesn't really flatten out. It just becomes less of a dome. It goes from more of a dome to less of a dome, more towards flatter than dome shape. That creates low air pressure in the lungs. So air comes rushing in. And then as that diaphragm relaxes, air passively moves back out again to reset that balance of pressure. And it's not here yet, but the diaphragm is a muscle. The diaphragm is a muscle. And in order for a muscle to contract, it needs to be told to contract. In order for a muscle to contract, it needs to be told to contract. We talked about that before, way back in the muscle section. And the way a muscle is told to contract is by nerves. In this case, it'll be the phrenic nerve. We'll see that coming up shortly. The phrenic nerve, spelled with a PH. Phrenic, P-H-R-E-N-I-C, the phrenic nerve. That is what tells the diaphragm to contract. There's a good term here, though, on this slide, the very top, mechanisms of pulmonary ventilation, right? Ventilation is the movement of air. Ventilation is the movement of air, replacing good air for bad air. No, reverse that. Replacing bad air for good air. And you've seen this on the label of maybe paint cans or something. It'll say using a well-ventilated area, or cleaning products or something. Using a well-ventilated area, meaning an area where bad air can leave and good air can come in. So slightly different. Inspiration, expiration. Inspiration is breathing in, expiration is breathing out. That is going to change the shape of the thoracic cavity. It actually changes it in 3 different directions. Remember, the ribs that start out in your back, those ribs start out on the thoracic vertebrae. And as they come around towards the front, they actually swoop downwards. But when we breathe in, we can see this movement of these ribs, often described as like a bucket handle, as they swing upwards as we breathe in to expand that thoracic cavity. It's also going to expand in the front, though, where the bones of the sternum are, kind of like the handle on a well, like an old well where you pump water out of the ground. Okay. So this diagram should really start down here. The diagram should really start down here with the diaphragm contracting, because that's the main thing that is going to cause air to come rushing in. And the deeper the breath, the more some of these other muscles are going to be involved in helping to get air to move in. And here it's demonstrating how those lungs are going to completely fill up that area of the thoracic cavity, or as much as possible. As compared to when the diaphragm relaxes, moves into that more dome shape. And if we want to force more air out, we can use these intercostal muscles to contract, coming together, creating a smaller thoracic cavity, squeezing the lungs to force more air out. And that's what that is demonstrating here. Let's see. Talked about that a little bit. Okay, one of these, the volumes of pulmonary ventilation here, these are kind of important. Pulmonary volumes, different volumes of air move in and out of the lungs. The important one, probably the most important one that I want you to know about, is the tidal volume. And the tidal volume is the amount of air that we normally breathe in and out. It's not just out. It says here breathing out, but it's the normal amount of air that we breathe in and out when we're sitting here not thinking about it. And it's about 500 milliliters. About 500 milliliters of air in and out. You're not even thinking about it. All morning you've been breathing, haven't thought about breathing probably, but it's been happening. That movement of air is the tidal volume, and it's about 500 milliliters. That movement of air is the tidal volume. It's about 500 milliliters. You can hear me repeating this, probably for a reason. You know, of all of these different measurements of air moving in and out of the lung, this one's the most important, because this is the one that we do without thinking about it. And this is the one that you definitely would want to know about. I would say this is the one you want to know about first before anything else. So if you breathe that air out, just not even thinking about it, you're breathing in, you're breathing out, you're not even considering it, 500 milliliters in and out. And after you breathe that last bit out, there's still air in your lungs that you could still force out if you wanted to. And you could sort of do this on your own. Don't take an extra deep breath in, just breathe normally. And then be aware that after you breathe out, now try and force more air out of your lungs. That's what's referred to as the expiratory reserve volume. That's what I call the forced air out of lungs volume. So it's not that you took an extra deep breath in, that's the inspiratory reserve, but you just were breathing normally, and then once you breathed out normally, there's still that extra air that you can force out. Now, and there's a lot of it, as you can see, about 1,000 milliliters. Then even after that, there is some air still in your lungs that you can't even force out. And that's the last one here at the bottom, called the residual volume, at about 1,200 milliliters. All right, so why do you care about these? If you're like, well, I can't even exhale that, so why does it make a difference? Or I hardly use that expiratory reserve volume, so why does that make a difference? Consider a person who's choking. In other words, something is blocking their airway. They cannot move air in or out, which means they cannot make a sound, they cannot cough. They're not saying, help me, I'm choking, can't breathe. They're not saying anything because they can't. There's no movement of air. They've got this fearful look in their eye. They've got their hands up to their throat. We know now, we all do, know that there's still air in their lungs. So if we were to squeeze their lungs like balloons and force that extra air to move out, we could force it to push whatever's in the way out of their trachea, for instance, and have it pop out like a champagne cork. Now, of course, because the ribs are in the way and the bones of the sternum are in the way, it makes it a little difficult to grab a hold of the lungs. So what we would do is we would get behind this choking victim and we would make a fist with one hand and place that just below the bones of the sternum, and then put our other hand on top of it. And we would give them a big hug, but we would squeeze forcefully in an in and then upward direction. So basically, we're trying to squeeze the lungs from beneath, where the diaphragm is. That's the soft area. And in doing so, squeezing the lungs that way will help use that expiratory reserve volume that we know is there and help move that object, whatever offending object is there in the way, to come flying on out. That's why we do that thing called the Heimlich Maneuver. We take advantage of the fact that we know that there is an expiratory reserve volume and even some residual volume. So of all of these, this is a nice graph because look right in the middle of it. Tidal volume, 500 milliliters. So you're breathing in, you're breathing out. That's the normal. You're not even thinking about it. That's the normal amount of air. 500 milliliters, we call that the tidal volume. And then you could see the differences with these other ones. With the expiratory, that's the extra air that we know we can push out. And then that residual volume. The inspiratory reserve volume, I didn't really go into that too much. But you know that if you needed to, maybe if you're swimming or something and you want to swim deep down into a pool or into deeper water, you can take one big deep breath. That's what the inspiratory reserve volume is, that amount of air that you can forcefully inhale, get as much air in as possible. On top of the tidal volume. So tidal volume, 500 milliliters. Good thing to know. Of these, I would say the most important one to consider is simply the total lung capacity. Add all these up. You get 5,000 to 6,000 milliliters of air. I don't worry about the other ones too much, unless you are going into pulmonary medicine. You can read those. That's about it. The term partial pressure. This is good terminology just to know, because oftentimes you'll hear and even see, like in a book, for instance, the way that they describe the movement of oxygen and that concentration gradient often includes the partial pressure of these molecules. That's about it. I talked about the exchange of gases, oxygen moving across the membranes. The nice thing about this diagram, is it sums up what I was telling you before. Notice how they consider the lungs, inside of the lungs, still considered external. Notice how they have the trachea, still external. Notice how they have the inside of the nose, a nasal cavity, still external. So this helps reinforce that idea that I was talking about before, internal respiration versus external respiration. So what you're seeing where the oxygen, for instance, moves out of the lungs and into the body, into the tissue, now it's crossing a membrane. So now it's going internal. All the rest of that is external. So it's actually a really simplified version of what I was saying. That's why I said that you could start up here and get a wire and move it into the nasal cavity, down into the throat, down into the larynx, down into the trachea, down into the bronchi, down into the alveoli in the lungs, without going through a single door and without going through a membrane of any kind. And it's not until oxygen moves across that membrane, now we call it internal. We've talked about blood transporting things, and we know that blood is full of red blood cells, which is why it's red. And we know the job a red blood cell has, which of course acts like a bus carrying oxygen. Yeah, red blood cells do carry some carbon dioxide. Yes, they carry nitric oxide. But the most important job of the red blood cells is carry oxygen. And a lot of that carbon dioxide, in fact, most carbon dioxide travels in the blood, but it changes into a bicarbonate, HCO3-. We know that red blood cells are full of seats for those passengers. And we know those seats are called hemoglobin. Hemoglobin is a molecule, made up of 4 chains. Adults there are 2 alpha chains and 2 beta chains. Most hemoglobin molecules in adults, or what we call adult hemoglobin, with 2 alpha chains and 2 beta chains. Babies have 2 alpha chains and 2 gamma chains, so their hemoglobin is different. There's iron in these seats, so that each one can hold 1 molecule of oxygen, O2. This is the quaternary structure of hemoglobin. Alpha 1, alpha 2, beta 1, beta 2, 2 alpha chains, 2 beta chains. Again, that's adult hemoglobin, which makes up, I believe, 95% of the hemoglobin that's in our blood is adult hemoglobin. Some have 2 alpha chains and 2 delta chains, and then the fetal hemoglobin is 2 alpha chains, 2 gamma chains. And we still make fetal hemoglobin, just small amounts of it. And you can see where those oxygens are sitting. Oxygen molecules, that's O2. That's molecular oxygen, not oxygen atoms. That's molecular oxygen, O2. So each of these groups is carrying a molecule of oxygen. You ever wonder why a whale can hold their breath so long underwater? Because they are oxygen breathing animals. They're mammals just like us. They have to surface to get air, but they can hold their breath a lot longer. The reason for that is not because they have bigger lungs, although they do, but because their hemoglobin molecules can hold twice as much oxygen as ours. So they don't need to come up as often. I think I talked about oxyhemoglobin and carboxyhemoglobin. I think I did. Yeah, oxyhemoglobin carries most oxygen transported. So in other words, most oxygen that's transported is sitting in a seat. Carbon dioxide. This is a little bit misleading, because actually most carbon dioxide does not travel being carried by red blood cells as carbaminohemoglobin. Most of it travels as bicarbonate. Carbon monoxide, this is the stuff that comes from car exhausts or furnaces. Carbon monoxide, that's CO, not carbon dioxide, carbon monoxide. Carbon monoxide binds the hemoglobin even stronger than oxygen, which is bad. So if someone is in a house and their furnace is leaking carbon monoxide into the house, and they don't know that, and they're breathing it in, they don't know they're breathing it in, doesn't have any odor to it, it's sitting on those seats and then it refuses to move. Which means now there's no place for oxygen to go, so it will not go in the red blood cells. The person will slowly start to get tired, pass out, and then die. So what we need to do with these patients who are carbon monoxide poisoning, first of all, move them to an environment where there is fresh air. So if they're in a house and it's leaking, get them to outside. Then we're going to give them 100% oxygen, because we are going to bully that carbon monoxide out of those seats. We're going to force it across those membranes and force it into those seats, just by putting more of it there. Okay. Let's see. There we are. As I said before, most carbon dioxide, CO2, the stuff that we create, remember this is a waste product, most of it gets carried in the blood in the form of bicarbonate, HCO3 minus. And that's important because this is one of the most potent buffers that we have in our blood. That ability to buffer the blood, in other words, raise the pH if it becomes too acidic, or to keep it from becoming too acidic. Remember, acid is when that pH number goes lower. Bicarbonate is a buffer. It helps to raise a pH. So in doing so, by keeping most carbon dioxide being transported in the blood in this form, bicarbonate, HCO3 minus, then we are going to be able to help keep that pH in our blood in a reasonable range of around 7.4 on average. Okay. So this is, again, just saying the same things that I said before. You'll notice that partial pressure of oxygen, PO2, as it is moving from blood into tissues, for instance. Notice where a lot of this stuff is taking place. A lot of this sensing stuff where our body has to determine if we are breathing correctly, if blood is pumping correctly, if the pressures are right, if the blood pressures are right. A lot of this goes right back to the brainstem. And you can see it here both in the medulla oblongata, which is a huge area for helping to regulate this, as well as the pons, the second part. And that is going to then, of course, make decisions, send information to the brain as well, which is going to send information back down again. Nice picture of the heart over here, because it shows the aorta, and then it shows the brachiocephalic artery, that first branch, which then branches off into the right subclavian and the right common carotid going up on the right side. And then the second branch of the aorta there that you can see off the arch is the left common carotid. And I mentioned before that at the bifurcation of the carotid arteries, there are sensing cells that will send signals back saying we need more or less blood, more or less pressure to these areas. So A lot happening here in the brainstem. I think a lot of this sort of makes sense. You know that when your body decides that it needs more oxygen, you're going to breathe more. When your body's utilizing more oxygen, you're going to breathe more. And since your heart and your lungs are closely related, if your heart is beating faster, you're probably going to be breathing faster because if you're pumping blood around. I think I mentioned this maybe last week or the week before. If a patient has tachycardia, they have a fast heart rate, and there's no reason for them to have a fast heart rate, like they didn't just get done exercising or something, or drinking a lot of coffee or medications or anything like that. One of the most common reasons for unexplained tachycardia is a pulmonary embolism, some sort of blockage that is not allowing blood to flow through those lungs and allow the body to pick up enough oxygen. The heart's going to beat faster to try to pump the blood through and around the body quicker. Let's attempt to get as much oxygen delivered as possible. So, fun fact. Already. Oh, wow, that was it. Okay, good. All right, I guess we're in a good place then. Go back to here. Okay. Any questions about that? You could see how towards the end it started to get a little more complicated. And like I said, I'm just going to skirt the surface of that because this is not an advanced anatomy and physiology class. Like I said, the paramedic students, when they have their advanced anatomy and physiology, it was mostly physiology that I would teach. And this is one of the areas that we would spend extra time in because they do have to have a really good understanding of this because they're going to be dealing with it on a regular basis. But for this class, I think just a basic understanding is good for now. That's why I didn't go too deeply into some of those things. Some of the basic terminology is what I want you to know. Tidal volume, that 500 milliliters. Okay. Any questions? Everyone good with this? But otherwise, you can see the anatomy is pretty straightforward. I mean, you have these tubes that just become one tube that branched off into two tubes, that branch off into a bunch of tubes that end in clusters of balloons. There's so many of these alveoli in the lungs. Most of the lungs are made up of just alveoli, which is why when you look at an X-ray, that whole area of lung is basically dark because, well, it's basically air. The lungs are mostly air, kind of like a bag of potato chips. You think you're getting a big bag of potato chips, but you open it up and there's like this much at the bottom. Mostly air. No potato chips in the lungs. Hopefully. You don't want that. All right. Well, if you think that was easy, just wait until you find out about the gastrointestinal system. Because the gastrointestinal system is really simple, very simple. One big long tube that goes through the body. That's it, for the most part. All right. Well, then we will start that in just a moment. So I'll be back in just a moment. Okay, we are back and we are going to talk about the gastrointestinal system. Let me give you a quick overview of that. So you should be able to see my screen in about 5, 4, 3, 2, 1, 0. Let's remove this. So if you think about person, we are really just one big giant tube food goes in. Some crust on that pizza. Food goes in here. What we do is we break that down into smaller pieces with our teeth, chomping it up. And then as those pieces move down through this tube, going into places like the stomach, they're going to be chemically broken down into smaller pieces. And then as they enter places like the intestines, they get broken down into the smallest possible pieces. And now these are pieces that we can actually absorb. But what happens to something that we cannot break down, remains too big, we can't absorb, it's just going to keep going through and then out as leftover waste. This is why when that child swallows a dime, it comes out the other end as a dime. It doesn't come out as a nickel and 5 pennies. It comes out as a dime. If the body can't break it down, or if the body can't absorb it, it's just leftover and it just keeps going through. So this is basically what human beings are, just giant feeding tubes that want to reproduce. And everything that we've evolved so that we've become better feeding tubes, so that we can see where food is and hear the dinner bell, or we can hear other feeding tubes saying, come and get it. We can move towards the food or run away from bigger feeding tubes that want to eat us. We can reach out and shake hands. Hey, how you doing? With other feeding tubes, or grab food, put it towards us. Everything we've evolved so we can become better feeding tubes that can reproduce. We are pretty simple if you think of us that way. Try not to think of us that way. It's a little bit weird. So where does the digestive system begin? Now, most people will say the digestive system begins with the teeth. to chomp, 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 chomp that stuff into smaller pieces. However, we know that the lips help in keeping food in our mouth, especially when we're babies. Imagine that baby who has a cleft lip, for instance. When they try to breastfeed, they're going to have milk leaking out because of that opening. They're not going to be able to feed as well. So if the lips aren't functioning correctly, that actually will impede feeding. Therefore, one can say, well, actually, the lips is where the digestive system begins. And I think that's pretty reasonable. Now, there's even some people that will argue that the digestive system begins with our preparation of food. Cooking it. Now, that's a tough one to digest, for lack of a better pun. How can cooking help us digest food? Well, and in fact, a lot of people will argue and say cooking actually destroys the nutritional value of food. It really doesn't. That's an argument that is somewhat outdated. The cooking of food does not really destroy the nutritional value. Not significant enough to say it's better to not cook food. So when people say, well, it's better to eat fresh, uncooked, crispy vegetables, not really. And I'll give you an example that will actually make sense for those of you who are thinking right now, oh, he's out of his mind. I'll give you an example. Go to the grocery store and buy a sack of potatoes. And then take those potatoes home, take a potato out of the bag, and bite into it. You'll find that it's difficult to eat a potato raw, and that as you chomp, chomp, chomp your way through it, it doesn't break down as much, which means it's not going to break down as much as it continues through. Therefore, you're actually not going to be able to absorb as many of the nutrients. And I know you'll say, well, isn't it just full of carbohydrates? Well, okay, yeah, there's a lot of starch there, a lot of carbohydrates. That's true, but I mean, we do need carbohydrates. So eating that potato raw, you would actually get less benefit from it. You really wouldn't be able to break it down as well as if you had, in fact, first cooked it and maybe mashed it, poured some gravy on it, served it with turkey and stuffing. Oh, that sounds really good. A lot of butter, sour cream. Oh, sour cream is good on that too. So when people say eating raw vegetables is better than cooked vegetables, not really. You're not really losing a significant amount of nutritional value. And in fact, you might actually be gaining the ability to absorb more nutrients from it. So whatever way you want to eat your vegetables, just eat your vegetables. Just don't cover them in too much butter and salt or ranch dressing or blue cheese or anything else. So that stuff, that takes a good healthy snack and turns it into a candy bar, basically. So don't do that. But I digress. This is our digestive system. So I think that we can all agree that absolutely the teeth is near the beginning. Yes, there's a good argument to say digestive system includes the lips, and since the lips precede, excuse me, the teeth, then yeah, you could say the lips might be where it starts. But there are those people out there who will say, I don't know, cooking that stuff makes it easier. So this is the digestive system. Really simple. One big long tube, as we will see here coming through. All right. Starts way up here. And then, of course, the pharynx, the throat, is going to be that common tube passageway that is both for food, drink, and air, but then it splits off into an air tube and a food tube. The food tube is the esophagus. That is a flattened muscular tube that extends all the way down into the abdominopelvic cavity. So there must be an opening in the diaphragm, which there is, that connects to the stomach. I wish they wouldn't have the liver in the way. You'd be able to see the stomach better, but the stomach. Notice how the stomach is one organ within the abdominopelvic cavity. So this whole area here is not your stomach. That is your abdomen, if anything. Or you can say, well, obviously, inside is the abdominopelvic cavity. The stomach is just one organ. And notice its location. It is located in the left upper quadrant. This is important because remember, in medicine, words matter. The way you describe something is really important. So if someone says they have a pain in their stomach, but then they point down here, well, then that's not their stomach, which means any diagnosis that could be made, it has to change, because this is going to have the pain being down here is not about the stomach. So it's important when we use these terms. That's why I stress this as much as I do, because it's going to definitely change the diagnosis. The stomach, again, is where the chemical digestion of food begins. And then it attaches to the small intestines right about here. The first part of the small intestines, you can't see, it's kind of hidden. That is the duodenum. And then it becomes the jejunum and ileum, which is this whole big giant mess of small intestines right here, which is about, let's see, jejunum is 8 feet, ileum is 12 feet, another 10 to 12 inches. So about 21 feet altogether of small intestines. And that is where the majority of the absorption of all those nutrients takes place. Then whatever's left over moves into the large intestines, right down here at the cecum, C-E-C-U-M, the cecum. Notice the vermiform appendix hanging right off of the cecum there. And then you'd see the colon moves upwards as the ascending colon, then across as the transverse colon. Then it goes down as the descending colon. Then it has an S shape to it, which is why we call it the sigmoid colon. And then that'll go to the rectum, which is the straight part. And you know it's a straight part because rectus, the Latin word for straight. So the rectum is the straight area right before the anal canal and the two anal sphincters that end the digestive system. So nice view of it. Now you'll notice they also include the liver here. The liver, largest solid organ in the body, located in the right upper quadrant mostly, but also into the left upper quadrant. The liver does over 500 different things, and it is involved with digestion. It is where Our body makes something called bile. Bile is that thick, yellow, bitter tasting stuff that you throw up after you've thrown up everything else. Well, when it's made from the liver, it's a little bit thinner. It's not as thick. And it is stored, some of it is stored and released from the gall bladder, which you can also see here. So these are accessory organs of digestion. And you can even see they point out the pancreas. The pancreas tucked inside of the loop of duodenum, the small intestines. We know the pancreas is the site of insulin production. We know it has produces different hormones like glucagon as well. But the pancreas plays a huge role in digestion. Remember, if you look at that drawing of the food tube, we have to take particles that are broken down and break them down even smaller. And the pancreas is responsible for making a lot of those enzymes that break things down even smaller so we can absorb them. So it's really important in that. And I said before, the pancreas is located posterior to the stomach, and the tail of the pancreas points over to the spleen, which you can just kind of see there tucked back away. But you can get an idea of its location at least. That's it, the end of the story. Well, not really. I'm going to go into a little more detail, but oh, and they do include here the submandibular, sublingual, and parotid glands are glands that create saliva. Saliva is very useful in that it helps mix with the food stuff, making it easier to swallow. There's an antibacterial property to saliva as well. It also contains an enzyme, helps to break down carbohydrates. However, we'll talk about that enzyme a little bit later on. That enzyme doesn't actually get activated till it hits the stomach. So the people might tell you that this amylase, this enzyme that's in the saliva, breaks down carbohydrates in the mouth. It doesn't really break down carbohydrates here. It just mixes with it. It doesn't get activated till it hits the stomach, and that's where it starts to break things down. Well, carbohydrates. You probably won't be surprised to find out that there's going to be a lining of mucus within the gastrointestinal system, because again, it helps to trap things. This right here is the, and again, this is just sort of a general overview of parts of the gastrointestinal system. This is the opening. This is the lumen through which food stuff will be passing, that tube area. But then, if you look here, there are layers of muscle. Oh, there it is. Circular and longitudinal muscle. The reason for this is because we got to move stuff through this tube, this long tube that we got running through our body. We got to make sure we're moving stuff through it. There has to be movement. And remember, that's the job of muscle. What does muscle do? It causes movement. How does it cause movement? By contraction. Contraction means a shortening of the muscle. So this muscle that is encircling this tube comes in two layers. There is a circular layer going around it. Then there's a longitudinal layer also around it, but going in a long direction. And you can see, of course, they're muscles, so they're going to have nerves attached to them. Why are there two layers? Well, if there was just a circular layer, for instance, when that muscle contracts, it would just squeeze, like if you put your hand around the tube, I don't know, and you squeezed it. If you put your hand in the middle of a big tube of toothpaste and you squeeze, stuff's going to move in both directions away from your hand. They're going to move in opposite directions. Well, we don't want that to happen here. We want things to move in one direction, just like we did with the blood. We want what we call this peristaltic action. Peristalsis is a wave-like motion, and we want that to occur pushing things in one direction. So these two types of muscles working together ensure that stuff continues to get pushed in one direction. That's why we have to have the two layers working together. Peristalsis is the term that you'll hear, and this is what is pushing things through. Pretty important, generally speaking. So at this point, it's nice that you can see these other layers around it. The mucosa, submucosa, muscularis, and then serosa. It's good to see these, but what I really want you to understand is that there's muscle, and there's a couple layers of muscle that are going to push things, propel things in one direction. We talked about the lips. Let's see. We talked a little bit about the palate already. In fact, the hard palate and the soft palate is really just the base. The hard palate is the bony part of the maxilla, and the soft palate is just the soft tissue. So here we have somebody opening their mouth, saying, ah. And you can see, obvious, the lips and tongue. The tongue is really important with moving food around, because when you chew food up, you have to move it around. That is a muscular structure. The tongue is a muscular structure that moves things around, and then will help move it back to the area where you can actually swallow it. The chewing of food is called mastication. And then the movement to the back to where you can swallow it is called deglutition. And then look at that little punching bag hanging down right in the middle. That is called the uvula. The uvula is going to initiate the gag reflex so that you don't choke on something and die. And this gives you a nice little picture here where you can see the palatine tonsils. Again, these are the tonsils that are usually removed when somebody has their tonsils taken out. These are the ones that get taken out. The adenoids you cannot see. They would be above and to the back a little bit more. And actually where this fauces are opening, that's really where the oropharynx is located. The middle of the throat is straight back. The tongue does have the lingula. Is that right underneath your tongue, right in the center, there is that bit of tissue that holds the tongue down. That's one of the reasons why the person can't really choke on their tongue like people think they can. It's really, you really can't move your tongue backwards that way. And the tongue is oriented in a forward direction. So when people think that when a person's having a seizure, that they're going to swallow their tongue, well, first of all, they can't swallow it. That would have to go down the food tube in order to swallow it. What they mean is that the tongue will block their airway, which really won't happen. unless there's been something happened to the tongue. Like if there's been severe damage and it swells up, but it would have to swell up a lot. It can do that in a condition called Ludwig's angina, which is a bacterial infection. It's a mixed bacterial infection, aerobic and anaerobic bacteria. That can be dangerous, but that's not terribly common. A person can bite through their tongue, and that is not fun. It's not fun trying to suture that up, that's for sure. But I digress. The tongue is very helpful in moving things around, moving things to the back. 3 major salivary glands: the parotid, submandibular, and sublingual. See those again. So if you look at the parotid gland, right, if you follow this over, it's more in the cheek. And if you were to open up your mouth, looking in a mirror, open up your mouth. In fact, let's go back to this picture here. Stick out your tongue and say, ah. And you sort of looked back in this area, kind of move some of that cheek out of the way, right? And back in this area here, you'd actually see an opening, a really small little opening, where saliva would come out of that parotid gland. Submandibular, you can figure out where that's located. Submandibular and sublingual. Even though these are smaller glands than the parotid gland, together they make most of the saliva that's constantly being produced. Note the epiglottis. Remember, the epiglottis is that lid-like structure that flips over your larynx when you swallow something. And we're not going to get too much into the anatomy. Oh, there's a picture of them. We're not going to get too much into the anatomy of the tongue. And you can see parotid, submandibular, sublingual. And they show part of the parotid duct is just a little bit high there, but they show part of it. Sometimes there can even be some calcification, some precipitate that occurs in the ducts of the parotid glands. And these little stones are actually little stones that can block the ducts. And you can usually sort of with your finger and thumb, with the thumb on the inside of the mouth, the finger on the outside, you can usually work it out. So you can sort of massage the stone all the way out. Sometimes occurs. But we'll talk about other stones that occur a little bit later on in the gastrointestinal system and the urinary system. Teeth. What do teeth do? Teeth are great for destroying things. Well, that's their job, isn't it? To tear things apart, to break things down. Baby teeth are the deciduous teeth, and then of course permanent teeth. Kind of easier just to see the basic parts of the tooth here, the crown, the neck, and the root. You can see how we have blood supply flowing up to a certain part, and then it kind of stops, and the dentin surrounds that. And then surrounding the dentin is the enamel. The enamel is the single hardest substance there is in the body, harder than bone. But it has to, because it takes a lot of mistreatment as it grinds against other teeth, as you're chewing up things, as you're chewing up solid things. It's going to have to be strong to hold up against those. And you'll notice this is all embedded in bone. So if someone has this tooth pulled out, including that root, that area is going to fill in with bone. And if a person has several teeth pulled out, those areas are going to fill in with bone, which means that area is going to take on a slightly different shape. And if the bone changes shape a little bit, that's going to change the shape of the face. It's not good. What else did I want to say about teeth? I think that's all I can think of now that I want to discuss with the teeth in that picture. It's good to know some of the basic names of the teeth. Incisors in the front, canines are the sharp ones just off to the side. The molars are the ones that are further back that do a lot of the grinding. Wisdom teeth is actually a name even for teeth. It's not officially a name, or it's like medically, scientifically. It's just, I think they're just the 32nd molars. That's all I have to say about that. Seems like there's something else I wanted to say. I can't think of what it was. The pharynx. The pharynx is the throat. Food bolus, which is really just a combination of food, mucus, saliva, all ground together, made into a liquidy paste that you're going to move from the mouth to the esophagus in a process called deglutition. The esophagus is a flattened muscular tube. Not surprisingly, it is lined with mucus. Extends from the pharynx to the stomach. There are a couple of doorways here called sphincters. And we'll talk more about the LES, the lower esophageal sphincter, in just a little bit. That's the most important one that you want to know about. So when you go to swallow something, you initiate that swallowing. You say, I want to swallow this now. And you voluntarily do it. So about the first third of your esophagus is under voluntary control. After that, it just continues all the way down through the diaphragm and into the stomach. And in fact, you don't have voluntary control again until the anus. So all of this stuff here is under involuntary control. First third of the esophagus is voluntary, and then after that, nope, moving along on its own. Notice how the esophagus goes through the diaphragm. There must be an opening, and there is. And then right where the stomach is met by that esophagus, there is something called the lower esophageal sphincter, or LES, sometimes called the cardiac sphincter, but nobody calls it that. Everybody calls it the LES, the lower esophageal sphincter. Well, why is that an important thing to know about? Because once we move things into our stomach, now there's a huge amount of acid in our stomach, and then we've created even more, knowing that we have food coming into there. So we create more. And we are going to move this stuff around as if it was in a washing machine. What we don't want to happen is we don't want that stuff to move backwards. So that lower esophageal sphincter is going to help us make sure that things do not move backwards most of the time. This is an important one to know about, as we'll see some of the pathology that can occur as a result of a lower esophageal sphincter failing. Stuff moves into the stomach. The stomach, notice how it has a sort of a rounded top to it right here. And then there's a small curved part here, and then a larger curve on this side. And then it comes down to a point, and there's a connection right here where it connects to the small intestines. Another muscular doorway, in fact, another sphincter. Oh, let me do this picture first. Okay, so the stomach is broken down into 4, sometimes 5 divisions. The cardia is the area of the stomach right next to the esophagus, which is why that muscular doorway is sometimes called the cardiac sphincter. Then the rounded dome-shaped part, that is called the fundus. That's a good thing to remember. And the reason it's a good thing to remember is because we will find other parts in the body, like the urinary bladder, that has a rounded dome-shaped part to it called the fundus. And we will find that the uterus has a rounded dome-shaped part to it called the fundus. So it's just a good thing to remember. If you can envision this stomach, that rounded dome shape called the fundus. The body, of course, the main area of the stomach. And the pylorus is where the stomach is going to meet that first part of the small intestines, which is right here, the duodenum. So a transition area from the body to the pylorus is called the antrum. So some books will have that listed as a separate part. However, I think most books now include it as part of the pylorus. So I wouldn't worry too much about that. But that transition from the body to the pylorus is called the antrum. But again, not to worry too much. The fundus is something you definitely want to know about because, again, you're going to see a fundus on the urinary bladder. You're going to see a fundus on the uterus. So here we are. The esophagus coming into the stomach is going to go through a muscular doorway called the lower esophageal sphincter. Here is that lesser curvature of the stomach, which means there must be a greater curvature, and there is. Then we see this stomach is cut back in layers. What are each of those layers representing? Muscle. We have longitudinal muscle, just like we saw in that earlier picture. We have circular muscle, just like we saw in that other picture. And then we even have oblique, in other words, at an angle muscle. Why do we have muscle going in so many directions? Because when that food stuff that we've swallowed down the esophagus is moved into the stomach, when it enters that stomach, it's going to get mixed around. We want it to mix with all of those chemicals, whether they're enzymes or they're acid. We want that stuff to really get mixed around. Again, kind of like a washing machine. And the best way to do is have a muscle oriented in different directions. So as it squeezes, 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 stuff gets moved around. the inside of the stomach have these folds called rugae. And the purpose of the rugae is to increase the area, allow for expansion of the stomach, kind of like an accordion. Kind of allows the stomach to expand, especially after Thanksgiving dinner with the turkey and the stuffing and the mashed potatoes and the gravy. Man, it was getting close to lunch. So we will see rugae again. This isn't the only place that we see rugae, but they allow for that expansion. Then the pylorus leads to the muscular doorway called the pyloric sphincter, which separates the stomach from the duodenum. So when you swallow something, it goes into your stomach. Actually, even before you swallow it, as you're chewing it up, your stomach is getting ready. It's saying, we got food coming. Let's start making some acid and enzymes now. As you swallow it, that goes into the stomach, gets mixed around. But for how long? That kind of depends. Anywhere from 30 minutes to about 2 hours gets mixed around. Not much else is happening in the stomach other than a lot of production of enzymes and acid and mixing. Do things get absorbed in the stomach? In other words, do they move into cells and into the blood? Yes, but not a lot. The notable things that get absorbed in the stomach would be ethanol, like alcohol, like an alcoholic beverage, and aspirin. Aspirin gets absorbed in the stomach. That's about it. Then after 30 minutes to 2 hours, the pyloric sphincter relaxes and things move out of the stomach. Now at this point, it's really just a lot of liquid. It's mostly liquid as it moves into the duodenum. The duodenum is the first part of the small intestines. Is about 8 to 10 inches long. It bends around. It plays a huge role, though. Yes, we talked about the sphincters, muscular doorways. Of these, let's see, of these cells in the stomach, which ones should you know about? The parietal cells. The parietal cells are good cells to note. Secrete hydrochloric acid, and they also secrete something called intrinsic factor. Intrinsic factor is important for vitamin B12 absorption. Your body does not absorb vitamin B12 very well all by itself. Pardon me. However, when vitamin B12 and intrinsic factor snap together, now the body can absorb that unit much, much easier. So the parietal cells are an important one to know for that reason, for the production of intrinsic factor and intrinsic factor's role in binding to vitamin B12 and making it, giving it the ability to be easily absorbed in the gastrointestinal system. Chief cells secreting pepsin. I don't need to worry about that too much, or the endocrine cells too much. I think I mentioned ghrelin in the endocrine chapter. Yeah, I did. Okay, so this is just a really enhanced view of the different tissue types in the wall of the stomach. Notice again, the muscle layers, oblique, circular, longitudinal, going in different directions to make sure that that stuff gets squished around. All right, talked about that a little bit. Limited amount of absorption, talked about that a little bit. Okay, the small intestines. So the diameter of the small intestines is not very big, but the length is. Like I said, the duodenum, the first part is about 8 to 10 inches. The jejunum, the next part, is about 8 feet. And the ileum is about 12 feet. So all of that together, about 21 feet. Wish they had a better picture of the duodenum, or actually all the small intestines. Duodenum is another pronunciation. I say duodenum. Duodenum is another pronunciation. I say duodenum. Either is correct. It is in the duodenum, the pancreas is tucked. I kind of do want to show this though. I kind of want you to realize what's happening here. Yeah, we should save him. He's nice. So if the duodenum's coming this way as this tube, and of course, from the stomach here, pancreas I always draw it kind of triangular. It's kind of triangular. It has tubes that are going to release enzymes into the duodenum. We also have one coming down from the gall bladder and liver this way, delivering bile. But the pancreas is going to release enzymes that are going to break down food products. Oh, not purple, I just used purple. From being somewhat bigger. Remember, these just came from the stomach, so they were broken down chemically into smaller parts. Now they're going to mix with these enzymes here. And what's going to happen is now we're going to end up with much smaller parts that are much easier to absorb. So it's really important the enzyme does this job here. So the duodenum does not absorb much either. The duodenum is really responsible for collecting these enzymes so that they can be mixed with these food products, these broken down food products. The only thing that does get absorbed here is iron. But remember, it likes to be with vitamin C in order to get absorbed. But iron, it's about the only thing that gets absorbed in the duodenum. That means the rest of the absorption is going to take place in those next two areas, the jejunum and the ileum. So there are specialized cells in these areas of jejunum and ileum. And you're going to say, oh yeah, I recognize those. Those look like cilia. They do look like cilia, but there's a difference. They don't move. These are villi and microvilli. So what's the purpose of these projections of the cells? Well, let's see. Here's our blood vessel running along here. So as things are moving through that lumen, we had dinner, turkey, some greens, carrots, other things. As we ate our dinner and we chomped it up and made it into smaller pieces and took those smaller pieces and made them into smaller pieces, and then in the intestines and the duodenum mixed with other enzymes made them into the tiniest little pieces. Now we're talking things like glucose size pieces. As this stuff is moving through these tubes, we want to have the ability to absorb as much of these small little pieces as possible. So by having these villi, we increase the surface area where things can get absorbed, as compared to if they were just flat on top, because now we can absorb things here and here and here and over here and this way. We could absorb things this way and all the way down here. And those particles get absorbed by the cells and then move into the blood, which of course is going to take this to the liver and determine what to do with this stuff. So especially you see this in the jejunum, the ileum, we see these cells that have villi and microvilli. They look like cilia, but they do not sweep. They do not move. They are just there to increase the surface area so that more things can get absorbed. So that's the idea. The duodenum, about 10 inches long. Jejunum, about 8 feet. Ileum, about 12 feet. Notice the spelling of ileum. I-L-E-U-M. That is different from the bone. Back to this actually. I-L-E-U-M. I-L-E-U-M. Looks like a loop of intestines. Because remember, I-L-I-U-M. Well, that's bone. That's an M. That's bone. That's part of the pelvis. I-L-E-U-M is that long part of the small intestines, about 12 feet. don't mix up the two, because I'll probably try and mix you up. I'll probably put it on a test. I'll probably say which of these is correct or something along that line. Ileum, ileum, small intestines, ileum, ileum, bone of the pelvis. Not to be confused with Elvis. Thank you very much. Not to be confused with the Elvis muscle, which is, of course, the longest named muscle in the body, the levator labii superioris aliquot nasi muscle. That does that thing with the upper lip where you go. Used to be called the Elvis muscle. All right, that's all I have to say about that. Any questions up to where we are now, or maybe down to where we are now, depending upon the perspective? No, no one. Okay, well then, I will take a break and I'll be right back. Okay, so we are back and we are going to pick up with large intestines. Let me make this easy for you, because that's what I do. I break it down for you. So you should be able to see my screen right about now, and it should look like this.
I got one more question about the final exam.
Yes.
This is how, so when we do all the homework and do well with the myths and voids, you got a little slide in the final. Does that help to pass you? Like you get 75 instead of 78, for example. But the midterm was good and you did all your homework and all your discussion. Does that help?
I don't know how that relates to the overall grade. And I say that because I was originally told that those grades are separate, that you have to maintain a 78% on both of those individual, and in the quiz test category and the homework discussion, etc. category are two separate categories. Each category has to maintain a minimum of 78%. That's what I was told. So that's what I sort of passed on to you. So that's my understanding of it.
Thank you.
So make sure that you do well on the quizzes like the one you have today. You have the cardiovascular quiz today. Make sure you do well on that, which means next week you'll have a quiz over the respiratory system and the cardiovascular system. So make sure you do well on those. What am I missing? Yes. So we've talked about the absorption that takes place in the small intestines. After all that food stuff has passed through the small intestines, anything that was too big or couldn't be broken out or couldn't be absorbed is going to then move into the large intestines. So here's the end of the duodenum. Things are moving this way. And they are going to move into this puckered pouch right here. And this is called the cecum. C-E-C-U-M. The first part of the large intestines. And you can see the appendix is hanging off right there. So then this leftover waste stuff moves upwards. And this is the ascending colon. Called the ascending colon because it's ascending, it's moving up. Then there's a bend right here. This is called a flexure, F-L-E-X-U-R-E. That bend is called a flexure. And because it's next to the liver, it's going to be called the hepatic flexure. Then the stuff moves across through the transverse colon. Now, to give you an idea of where this is located, the umbilicus or belly button is right about here. So if you're trying to imagine where one would find their transverse colon, just above the belly button a bit. Then there's another flexure, another bend. Right here, called the splenic flexure. Because it's, near the spleen. Things are going down. So this is going to be the descending colon. Then there's an S-shaped part. It's sort of an S shape there, but it is an S-shaped part. This is called the sigmoid colon, because the Greek letter for S is sigma. So they called it the sigmoid colon, which then comes around back this way and into the straight part called the rectum. Because rectus is straight, and then to the anal canal and the anal sphincter. Actually, there's two anal sphincters where we once again have control, voluntary control. So whatever we couldn't absorb moves into the large intestines. Now, the large intestines has a greater diameter, which is why it's larger, but it's only about 6 feet in length, which confuses people. They think, well, why is it called the large intestines if it's shorter than the small intestines? Well, because it's the diameter that's larger. The first part of the large intestines is called the cecum. This is where the ileum comes in. And hanging off of the cecum is the vermiform appendix. The vermiform appendix is part of the immune system. So it plays a role very, very similar to what tonsils would do. So for people who try to tell you the appendix is a vestigial organ, that it doesn't do anything anymore, that's actually not true at all. It definitely has a role, it definitely does something. However, much like the tonsils, it can become more of a problem than it's worth. So much like the tonsils, it can be removed. And if this thing ruptures, if it gets infected, infection means inflammation, inflammation means swelling, swelling means pressure. Pressure means rupturing. If it ruptures, it can rupture and release content of the intestines into the abdominopelvic cavity, causing puerperal fever or a peritonitis, and also into the blood, causing septicemia, so this can be dangerous. And there was a time where an appendix would be removed just because it was there. In other words, if the surgeon was doing surgery in the abdominal pelvic cavity and noticed that the appendix was there, they would just take it out, saying, well, we don't want it to cause any problems later on. But of course, now we know we don't just arbitrarily remove body parts if we can help it. So as this waste product, this leftover waste product, moves through the large intestines, it first goes up. That's why it's called, oops, that was supposed to be red. That's why it's called the ascending colon, because it goes up. Then it goes across. That's why it's called the transverse colon, because transverse means across. Then it goes down, which is why it's called the descending colon, because it goes down. Then it comes to the S-shaped part. And again, sigma is the Greek letter for S. So when they were naming this, they said, hey, that looks like an S-shaped part. So they called it the S-shaped part. It's exactly what sigmoid means. Excuse me, the sigmoid colon shaped like an S. So they said that part looks like an S. So let's call it the S-shaped part. That goes into the straight part, which is called the rectum, because rectus means straight. So what else would you call a straight part other than straight? And that's what they did. Pretty simple. The bends, the flexures, are pretty easy to name. One's on the liver side, one's on the spleen side. So that was a no-brainer. And when you're doing a colonoscopy, for instance, where a camera goes up through the rectum and going backwards, you can use these flexures as landmarks because the inner diameter, the lumen, takes on sort of a triangular shape at the flexure. So you can always know that, oh, now I've got to the splenic flexure because I see the change in the shape. But that's about it. Now, does anything get absorbed in the large intestines? Your first impulse would be to say, well, no, everything got absorbed in the small intestines. No, we can still absorb things here, but mostly it's limited to things like salts, water. We do a lot of water reabsorption here if we need it, and vitamin K, because a lot of the bacteria that live here make vitamin K. So we take it. We say, hey, if you're not going to use it, we'll use it. So that's the simpleness of the large intestines. Notice I drew it sort of puckered, has these puckered pouches. These puckered pouches here called haustra, which again allows for expansion, hold more. That peristaltic action is going to continue through, so there's muscle in these walls that's moving things through. And you can hear that. That's the borborygmus. That sound of gurgle, 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 moving stuff through. It's called borborygmus. That's a good thing. That means things are working the way they're supposed to. FYI. Okay, so let's go back to this part. Large intestines. Diameter is bigger, length's about 6 feet. The cecum is the first part. There's a pretty good drawing there. Okay, I guess I didn't need to do that. The cecum is the first part. You can see here, ileum, I-L-E-U-M, coming into the cecum. So now everything that has been removed that we can remove for the most part, mostly what's left over is leftovers, stuff we couldn't absorb, stuff we couldn't break down. You can see the vermiform appendix, the appendix hanging off the end, the ascending colon going up, the hepatic flexure of the bend there, the transverse colon going across, the splenic flexure to the descending colon, to the sigmoid colon, to the rectum. And you can see there are the anus and the sphincter muscles. There's an external and an internal. I don't know if they don't show the internal. No, okay. Notice this other thing here called mesentery, this yellowy stuff. What it does is it helps to keep blood supply going where it needs to go. It attaches to the intestines, large and small, and also helps to keep everything sort of in its place. The intestines have the ability to move, to shift around to a certain degree, but not a lot. But again, because these things can move, that means they could potentially rub up against stuff, and that would create friction. And one thing the body does not like is friction. So we'll see that there's a lining that covers the abdominal pelvic cavity, parts of it at least, called the peritoneum, which becomes continuous with the mesentery. And there's also a big yellow fatty pad that sits right in front of us called the omentum. So here it is demonstrating that double lining around the organs, again, to allow these things to move with some degree without rubbing up against other things. Notice the areas in green, the retroperitoneal areas, some of the things that we see there, like the pancreas in the retroperitoneal space. Doesn't show the kidneys. Okay, well, the kidneys would be in the retroperitoneal space as well. The omentum, you're seeing a side of it here, is a big yellow fatty pad that hangs down and helps to protect the organs, as well as helping to keep them in place a bit. Vermiform appendix, or people just call the appendix, 3 to 4 inches in length, although it could be up to 8 inches, maybe even more, but it's usually somewhat short. Okay, there's the, oh, it's not a good picture, at least not yet. The mesentery, a fan-like projection, extends, helps to, I showed you, attached to the intestines, for instance. And then the omentum, don't worry about greater or lesser. Just know that there's a big, ugly, yellow, fatty pad that sits in front of everything. Helps to protect and keep things in their place. The liver is the largest solid organ in the body. In the abdominal pelvic cavity, it is located in the right upper quadrant mostly, as well as the left upper quadrant. You can see that there's lobes, but don't worry about the divisions. The round ligament actually starts out, and the falciform ligament actually starts out as early on as the part of the connecting vessels for the umbilical cord. But that's not what I wanted you to know about. You can see where the gall bladder is located, sort of underneath, just behind a little bit, has kind of a deflated pear shape to it. That's the gallbladder. It's green and ugly. Kind of looks like a deflated pear. has the ability to repair itself really well, the liver does. And one does not need a complete liver, or a completely functioning liver, that is, in order to live. The liver can work on partial ability, I guess would be a phrase for it. We talked about this before. Remember, I said the portal vein isn't really a true vein, because what it does is, although it collects from all these other veins that collect things from the stomach and intestines, it then branches back off again. And that's what's being demonstrated here. And as it goes into the liver, it branches off, and then into each of these divisions branches off even more. And the reason the blood does that is because it just picked up a whole bunch of nutrients. So now the body has to determine what we should do with these nutrients. Where do they go? Should we store them? Should we keep them in the blood? What should happen? And then all that blood comes back together, reforming this hepatic vein at the top, you can see here, which then goes into the inferior vena cava. So that's why the portal vein isn't a true vein, because veins should go from smaller to larger to larger to larger. In this case, it goes from smaller to larger to larger, and then suddenly branches back off into smaller again before coming back together. I showed you the bile ducts a little bit, but let me show it this way. This is a good image of both the gallbladder, the pancreas, and where they sit in the duodenum. Remember, the end of the stomach is right here. So the pyloric sphincter is right here. Stuff's moving out of the stomach and into that first part of the small intestines, the duodenum. As that's, we call that, at this point, we call it chyme, spelled C-H-Y-M-E. And the chyme moving out of the stomach, pretty much just liquid, or mostly liquid at this point, moves into this small intestines, the duodenum. And you can see there are ducts coming from the pancreas, as well as the liver and gallbladder. And those are going to converge and release these enzymes right into that first part of the small intestines, the duodenum. So now the stuff that was broken down in the stomach is going to get broken down even more. The gallbladder is going to collect bile. Remember, the liver makes the bile, but the gallbladder is going to collect some of that bile. It's going to concentrate the bile, and it's going to store the bile. So the thickened, concentrated bile is getting stored in the gallbladder until it gets the signal that a fatty meal is coming through, because bile emulsifies fats. Bile breaks down fats. So when a signal comes through, and the signal is a hormone called cholecystokinin, CCK, the gallbladder will squeeze out that bile, and you can see the pathway right down in through the pancreas and into the duodenum. Now, sometimes that bile can precipitate. In other words, form stone-like masses. And when that happens in the gallbladder, when that gallbladder squeezes, that'll hurt. Or it could get stuck in this passageway, and the gallbladder will squeeze, and the pressure of trying to squeeze past this will hurt, cause pain. So we take the gallbladder out, which means that the common hepatic duct will just stay the common bile duct. We just take it out right there. And then the liver will still be producing bile, but it just can't produce thickened, concentrated amounts of bile all at once. So we have to tell the patient, make sure that you eat meals that are lower in fat. Otherwise, you're going to end up with some gastrointestinal upset, because If you can't break something down, it just keeps going through. And if you can't break down fats, the person takes in a lot of fats, they don't have to bother to break it down. The fat's just going to slide right through. And when I say slide, I mean it slides right through, because fat is greasy and it could slide right out. You don't want that. So good image of the gallbladder, the pancreas, and the duodenum there. What does the liver do? 500 different things, so a lot. Talked about the gallbladder already. We've talked about the pancreas, this lumpy, grayish, yellowish, pinkish, almost triangular shaped organ. We talked about the different endocrine functions, creating glucagon from the alpha cells and insulin from the beta cells, for instance. Those are the ones that are most important. The acinar cells don't worry so much about. Okay, where are we here? All right. Ingestion, food's taken in. Digestion, food gets broken down. We're going to have to secrete stuff. So there's secretion of enzymes. Absorption. Now we're moving stuff into the cells and into the blood. Elimination, getting rid of things that weren't absorbed. And of course, regulation is regulation. Mastication, I told you this already, the breakdown of food products. And then once you break it down, you want to move it back to the swallowing area. That is the process called deglutition. Deglutition. The tongue is involved in that to help move it back. Remember, I said that the first third of your esophagus is under voluntary control. And then the rest of it after that, all the way through, is involuntary until it gets to the rectum and anus. This is the term I said you're going to hear me say a lot about, peristalsis. Peristalsis is this wave-like motion that causes movement produced by muscle that is oriented in different directions. That is going to help move things through. So we actually saw peristalsis in the arteries as well, moving blood through. We'll see it again in the urinary system, getting the urine from the kidneys down to the urinary bladders, for instance. Oh, and here is chyme. I didn't think they included it here. Chyme, C-H-Y-M-E, chyme. That is all that food type product mixed with mucus, mixed with saliva, mixed with acid, mixed with stomach enzymes, all mixed together. And this is just demonstrating that wave-like motion peristalsis that's pushing stuff in one direction. This is demonstrating how stuff gets moved around in the stomach. Again, much like a washing machine, we want to make sure everything gets mixed together really, really well. Hydrolysis is a term that we talked about actually way back in week 3, I think, chemistry. Remember, lysis means to break apart. Hydro means water. So hydrolysis means we're breaking stuff apart using water. We've talked about enzymes. Remember, enzymes are proteins. We make 2 things in the body more than anything else. We make energy and we make proteins. And many of those proteins can be structural proteins, like they're building something or they're a part of something. And then many of those proteins are enzymes that are going to be involved in a chemical reaction. And that is going to make something, break something, move something. Everything that happens in our body is the process of these chemical reactions. So there's lots of enzymes that are required. Remember, how can you tell the difference between an enzyme and a sugar? Yes, that's correct. Sugars end in -ose. Enzymes end in -ase. Carbohydrates. Carbohydrates are made up of sugars. So we're going to break those apart using an enzyme called amylase. Amylase is found in your saliva, and amylase is also found as a pancreatic enzyme. Even though it's in your saliva, it doesn't get activated until it hits the stomach. By the way, chewing gum is made up of carbohydrates. So if you swallow chewing gum, it will not stay in your intestines for 7 years. It is made up of carbohydrates. It will be broken down just like everything else. Not that I'm saying you should swallow chewing gum, but it's not going to get stuck there. And then looking at these other enzymes. Oh, look at this, sucrase. I wonder if that's going to break down. That's probably going to break down a sugar. Probably going to break down a sugar, something like, I don't know, sucrose. Maltase, that might break down a sugar that we call maltose. I don't know, who knows. And lactase, that's an enzyme. Lactase, that's going to break down some kind of sugar. Lactase is probably going to break down a sugar found in dairy products called lactose. So if a person is not making enough lactase, then they cannot break down that sugar, lactose. Lactose is the sugar, and it is made oh, that's one too short. It is made of these two sugars. So what we want to do is we want to get an enzyme. Oh, wait, let me point this out here. Remember, if something is too big, we can't break it down, we can't absorb it, it just keeps going through. This sugar's too big. So what we want to do is we want to get an enzyme called lactase that is going to break this into two separate sugars, glucose and galactose. These we can absorb. That big sugar we could not without lactase. So if someone is not making enough of that enzyme lactase, we'd say that that patient is lactarded. No, we don't say that. That's not nice. We say that they are lactose intolerant. Now, some people might make some of that lactase, so that if they eat pizza with cheese on it, they're fine. But if they ate or maybe drank a big milkshake, then they would have some gastrointestinal upset, because that big sugar would just keep going through, and all those bacteria that are there saying, hey, you're not going to use that sugar, we'll use that sugar. And the bacteria will take the sugar, and then they will create methane. They'll create gas. And then they'll create there'll be a creation of solid particles, which will cause water to move into that area, which will cause bloating and diarrhea. And that's uncomfortable. So if the person is making some lactase, well, they can eat some amount of dairy, but if they take too much dairy, then they have a problem. Today, you could walk into a pharmacy and buy lactase off the shelf in a little pill form, so that if you know you're going to eat ice cream, all you have to do is take one of these first. And you really have to take it right before you eat it, because remember, this enzyme is going to break stuff down. So if you take it an hour too early, it's already going to be gone by the time you get that ice cream down into that area. So you want to take this right before you eat that stuff. How can you tell lactose is a sugar? Oats. That's a sugar. How can you tell lactase is an enzyme? Ase is an enzyme. I think you've heard that a lot over the past several weeks. You'll probably hear it again. Look at that big carbohydrate coming in, big branched, chained bunch of sugars all stuck together. Breaking that stuff apart, making them into smaller sugars, then making them to the smaller sugars, and making them to the single sugars, and then you get the ability to actually absorb the stuff. Protein digestion. Now, proteins come in. What are we going to do? We're going to break them down into their individual amino acids. Remember, proteins are made up of these building blocks we call amino acids. So we have to be able to absorb these. So the stomach is going to break down the food stuff and separate out the proteins. Sort of just grab a hold of them and say, okay, all the proteins, you go over in this corner, everything else go over there. And then it goes into the intestines. Then we have these other enzymes, proteases and peptidases. They're going to break them down into the smallest possible amino acids, the building blocks, or as I call them, the Lego blocks. And now we can absorb them, and we could use them to, well, you guessed it, build up and make more proteins again. Fats are emulsified by bile. Emulsification is the breakdown of fats into fatty acids, into something that's small enough for us to actually absorb. Large fats get broken down to smaller fats eventually. And a lot of these will be absorbed, these fatty acids will be absorbed in the lymphatic system, which we might come back to maybe next week. Sort of trying to catch up a little bit where we are. We talked about saliva. It's going to help lubricate, to move things around. It's going to have those enzymes in it. I said, don't worry too much about pepsin coming from chief cells, the parietal cells, making intrinsic factor. That's probably the most important thing when it comes to these from the stomach. The parietal cells making intrinsic factor required for vitamin B being absorbed. That comes into play when someone has gastric bypass surgery, or they've had some sort of injury where part of their stomach was removed, like literally the stomach part of it was taken out of the person's body. When that happens, they're going to lose parietal cells. And when they lose parietal cells, they lose intrinsic factor. When they lose intrinsic factor, they lose the ability to absorb vitamin B12. So we are going to make sure they get enough vitamin B12 by giving them 100 times the daily recommended allowance. Because again, we're going to use simple diffusion. We're going to put enough of it on one side of the membrane, going to force it across. Okay, I wonder what these things here are. Trypsin, can't really tell. Amylase, you know that's an enzyme. Lipase, you know that's an enzyme. Nuclease. It's often called RNAs and DNAs, by the way, these nucleases. Trypsin is one that is an enzyme, but it does not have the A's in it. Lipase, remember, if you consider basic medical terminology, I told you that A's means it's an enzyme. Lipo means fat. So you know that's going to be some kind of enzyme that's going to break down fats. Oops, didn't want to do that just yet. And we talked about bile enough. Goblet cells make mucus. Olfactory and visual stimuli can cause the release of some salivary secretions. In other words, it's dinner time, you're hungry, you're standing in line at a fast food restaurant. I don't want to mention any names, but you're loving it. And you're smelling the food and you're looking at the menu and you already have saliva dripping out of your mouth. Well, hopefully not dripping out of your mouth. That could be rabies. Okay, you can read about the phases of how the brain interacts with this. Cholecystokinin, again, that's one that is going to cause bile to be released. Absorption, getting the things in, we talked about that. Elimination, getting rid of what we don't need. Constipation, things are going too slowly. Extra water is absorbed. The number one ingredient in every single medication, or I should say treatment option, for constipation that you can purchase in a drugstore is fiber. So whether it comes as a pill, as a liquid, as a chewable, doesn't make a difference. The main ingredient is fiber. Fiber doesn't break down very well, but man, when it gets to that large intestines, it acts like a sponge, meaning it just absorbs water, it just brings water. So if you mix that in with an area that doesn't have water, then water is going to go rushing to that area. So it helps with that. Diarrhea, things are moving along too quickly. There's a couple of different ways that this can happen, or reasons this can happen. Dia, remember, rhea, R-R-H-E-A, means excessive flow, and dia means complete. So an excessive flow that is complete, or a complete excessive flow, pretty much sums it up. So when a person takes something like Imodium that they would buy over the counter for this as a treatment option, what that actually does is it slows down the peristaltic action in the intestines, which allows more water to be reabsorbed, which is why it stops that in many cases. Okay, the last thing I want to talk about, because I think we got to the end of the slides. We did. Nice. Man, I am good. Last thing I want to talk about very quickly, fun thing. Not really fun. I think it's fun. Gastritis. Gastritis, inflammation of the stomach. An acute infectious gastritis is what people would refer to as food poisoning. The most common cause of acute infectious gastritis is a bacterium called Staphylococcus aureus. That's the same bacterium that causes staph infections. That is the same bacteria that causes most skin infections. Remember, if there's an infection in the skin, we assume it's bacterial. And if we assume it's bacterial, we assume it's Staphylococcus aureus. So this is the person who left the potato salad out after the picnic all day long, all night, for breakfast or for lunch, maybe even. Was still sitting on the counter. The next day, they decided to just start digging into it. And then about 2 to 8 hours later, or in some cases as early as 1 hour later, the person will feel like they're going to throw up, and then they eventually throw up, and then they'll feel better for about 10 or 15 minutes, and then they'll start to feel not so great, and then after about 45 minutes, they feel like they're going to throw up again, and then they'll feel like they know they're going to throw up again, and then they're going to throw up again, and that's going to happen every hour on the hour for the next 6 to 8 hours. You could almost set your watch by every time they throw up. There might be a little bit of diarrhea, especially thrown in at the end just for kicks. But the body's doing exactly what it's supposed to do. So we don't really need to treat this with anything after it's all said and done. They're going to be dehydrated, get some fluids in them. That would be a good idea. But they don't need any antibiotics or anything. Everything's out. They threw it up. And you can spot this when they come into an emergency department, because dad and the one kid are both going to be sick and have been throwing up the same amount of times. Mom and the 2 other kids are fine. And all you got to do is say, well, what did you 2 eat that the other 3 didn't eat? And you can narrow it down pretty quickly. This is the most common type of food poisoning, caused by one of the most common bacteria, Staphylococcus aureus. But you don't care about that one, or that one, maybe you do care about it, but that one's not a surprise to you because Staphylococcus aureus already caused all kinds of stuff. This next one, however, is going to be a surprise to you. You're not going to believe me. You're going to think I'm lying, but I'm not. The second most common cause of acute infectious gastritis, food poisoning by a bacterium, is caused by Bacillus cereus. Bacillus cereus, or B. cereus. Now, the signs and symptoms of this are very, very similar to what you would see in Staphylococcus aureus. Same throwing up, although it might go for 8 to 10 hours, might go a little bit longer. There's always diarrhea with this one. And in staph, they're going to feel like they were beat up with a baseball bat for about 24 hours after it's all said and done. With the Bacillus cereus, they're going to feel like they were beat up with a baseball bat for about 2 days after it's all said and done. But here's the thing, and here's the part that you're not going to believe me. The way that a person gets food poisoning from Bacillus cereus is from eating reheated rice and reheated pasta. And I know you're thinking, what? I do that all the time. Well, I don't mean you take leftover from the Olive Garden out of the fridge, stick in the microwave, heat it up, and then eat it. Obviously, when you microwave that and it's piping hot, yeah, that's going to kill pretty much everything. I mean, when you go to one of those buffets where they have the rice or the noodles out, and at the end of the day, there's still half a pan left. And they take that half a pan and cover it with plastic wrap and put it in the walk-in freezer for the next day. Now, technically, that's fine. But the next day, what they have to do is they have to heat that up back up to the original temperature before putting it out on the steam table. Unfortunately, sometimes people take shortcuts and they just take it right out of the freezer, right out of the walk-in and put it on the steam table. And instead of killing everything with the heat that would normally happen, that steam table just gradually warms things up, causes that bacteria to grow. And it's like a jacuzzi, causes them to grow and grow and grow. So if you go to one of those restaurants where they have rice and stuff sitting out that may have been out a little bit longer, maybe through one of those places in the mall, and you're going to get, they coaxed you in with their bourbon chicken samples, which are always so good. Just ask them to throw it in the wok. Get all the noodles, put everything together and throw it in the wok for just a few seconds, because that wok is so hot, it'll kill all kind of stuff. So Bacillus cereus, yeah, I know. Can you really get food poisoning from eating reheated rice and reheated pasta? Come on, be serious. Yep, be serious. Bacillus cereus. An acute non-infectious gastritis would be something caused by, let's see, what would cause this? Aspirin? And a chronic infectious, boy, I have 2 minutes left. Chronic infectious gastritis, Helicobacter pylori, H. pylori. This bacterium causes ulcers in the stomach. H. pylori, Helicobacter pylori. And a chronic non-infectious gastritis, alcohol. I mean like ethanol, alcohol. I don't mean like rubbing alcohol. I mean like the alcohol that you would drink. All right, that's it. So as I said, the anatomy of the gastrointestinal, the whole gastrointestinal system is probably the easiest of all of the body systems. So that one's not too bad. The respiratory system, the physiology gets complicated, but the anatomy isn't too bad either. So hopefully you learn some from that. But right now, you should have a quiz coming available. This is the cardiology quiz. And I am going to say goodbye. So goodbye.